Good morning. This is part 4 of common OPD cases in ophthalmology lecture series. For today, we will be discussing lid malpositions, strabismus or ocular misalignment, and ocular pharmacology. I am Dr. Darby Santiago, your lecturer for today. To start off, we will go on lid malpositions. You will have to recall that the eyelid has two parts, divided into the anterior lamellae and the posterior lamellae. There is a balance between the two of them, and whatever imbalance happens, or a shortening or a elongation of the other part, will lead to entropion or ectropion. Entropion is the inward rolling of the eyelid, while ectropion is the outward rolling of the eyelid. Shown in the photos are examples of your entropion. When you describe, there is a straightening of the eyelashes upwards, and at times there is also touch of the eyelashes at the inferior limbus or inferior corneal area. The lower photo shows your ectropion with consequent exposure of the conjunctiva. Ectropion, the causes of usually the causes of ectropion and entropion are neurogenic, involutional, congenital, or mechanical, and even traumatic. For entropion, the main causes are your congenital, or it could be due to a cicatrizing conjunctivitis, your seasonal sore eyes. It can also be due to trauma, chemical injuries. It can be involutional, meaning due to age, and it could be to Stevens-Johnson syndrome. The symptoms of entropion are usually due to the irritation that happens when the eyelashes touch the cornea, and this can be your red eye, pain, tearing, mucoid discharge, and there could even be partial loss of vision. For ectropion, the main causes are usually paralytic, a facial palsy. It could also be involutional due to aging. It could be due to trauma. It could also be due to a tumor. If the tumor is too big over here, it can cause shortening of the anterior lamella. It can also be due to scarring because of burn injury, which results to shortening again of the anterior lamella. The symptoms of ectropion would be tearing, constant eye redness, keratinization of the conjunctiva, and foreign body sensation. Now let's move on to the eyelid opening or the aperture abnormalities. The normal opening of the eye usually is about 5 to 7 millimeters. The upper eyelid usually rests about 2 millimeters below the upper limbus of the cornea, while the lower eyelid margin usually rests at the lower limbus. So anything beyond that can be called normal. First, we discuss ptosis. The upper picture here shows ptosis. You will notice the upper lid is way below the 2 millimeters of the upper limbus. The ptosis is unequal. Both eyes have ptosis. This could be involutional ptosis, meaning due to aging. Other causes could be your congenital, due to trauma, which could have severed a nerve, due to diabetes, myasthenia gravis, Horner syndrome. Some sudden onset of ptosis can be due to intracranial problems like aneurysm and intracranial hemorrhage. So you have to get a very good history of the patient, because this can be a very important sign that something is happening inside the head. You should also be wary about pseudotosis. Pseudotosis is actually maybe due to contralateral eyelid retraction. It is the other eye that is retracted. It could also be due to enophthalmos. Okay. It could also be due to eyelid pressure, such as dermatochalasis, tumor, or a brow ptosis. Spasms like blepharospasm and hemifacial spasms can also cause ptosis. Now, what do you ask about the symptoms of the patient? Usually, you will see that the patient has tilting of the head backwards, or there is a raising of the eyebrows, such as this our case here. There is usually dry eye and a watery eye, a feeling of tiredness in the eye, a dull pain in and around the eyes. Now, how about lid retraction? Lid retraction is most commonly due to thyroid eye disease. It is the most common unilateral or bilateral etiology of lid retraction. Now, what do you do if you have lid retraction? No? The signs and symptoms first. There's usually scleral show. There is what you call the staring appearance. The patient will complain of dry or watery eyes. There can be soft tissue lid swelling, and worse, you may have optic nerve damage due to the compression of the optic nerve by the extraocular muscles at the orbital apex. Now, well, surgical intervention is can be done, no, but only when there is stable endocrine status for 6 to 12 months. The eyelid height should also be stable before doing the surgery. There should be significant exposure keratopathy, lag of thalamus, or the inability to close the eyelids completely, if there is chronic conjunctival congestion, and if there is cosmetic imperfection. Now, let's move on to strabismus. It is easy to recognize patients who have cross eye. You just stare at them, look at them, and then you will notice that one eye could be deviated inward or it could be deviated outward. However, you have to be very astute in differentiating strabismus in children. If you look at the pictures below, you will notice that both would have an esotropia or inward movement or inward deviation of both eyes. However, if you look closely at the pupillary reflex, you will notice that this patient has a pupillary reflex at the edge of the pupillary border. However, in this other patient, you will notice that the pupillary eye reflex are central in both eyes. So this patient has no strabismus, while this patient has strabismus. Okay, what is the meaning of a patient coming to you with strabismus? First, it could just be a plain and simple muscle imbalance in the eye, in both eyes, in one or two eyes of the patient. But you should not be too relaxed about this problem, because it can herald a deeper problem, which is poor vision in the patient. Poor vision can be due to an error of refraction, a retinal problem, cataract, and other problems inside the eye, which hamper good vision in the patient. If there is good vision in the patient, then the patient may report to you diplopia. You can also ask the patient if there is alternating esotropia or deviation. If the patient or the parent reports alternating deviation, then you will be rest assured that this patient has good vision. You should also be careful when you encounter children up to 5 years old or 7 years old with deviation. Why? Because eye deviation can be a presenting sign of retinoblastoma. It is a very lethal cancer, and which can easily be cured by removing the affected eye. In this case, the patient here shows eye deviation associated with leukocoria or white pupil. Now, a patient to you comes with a straight gaze. However, the parents say that there is sometimes they see their child with a deviated eye. So how will you confirm this? You will have to cover one eye of the patient with an occluder. You occlude the eye for about 1 minute or 2 minutes, and ask the patient to just look at you straight. Then you suddenly remove the eye, the cover, the occluder. If you check the eye that was occluded, if it is deviated inward or outward, then you can conclude that the patient has aphoria. If after removing the occluder, the eye is deviated inward, then you have esophoria. But if the eye is deviated outward after removing the occluder, then you have exophoria. Tropia is used for deviations that are seen, that are manifested easily. How do you treat strabismus? Most of the time, we try to refract the patient after excluding problems in the retina, the vitreous, after excluding the presence of tumors. We go to do and refract the patient. and give the correction to this patient. Usually, when you give the correct refraction to the patient, the eyes straighten out on their own. For persistent strabismus or deviation, surgery is usually recommended. Now we're done with eyelid malpositions and strabismus. Let's now go to ocular pharmacology. We shall be discussing the more commonly used medicines or topical drugs in ophthalmology. There are a lot, but we shall limit our discussion to the more commonly used ones. Let's just first use these ocular diagnostic drugs. So first of which is your fluorescein dye. This is a very useful diagnostic tool because we use this to diagnose corneal abrasions, dry eye, okay? So you can bring this to the community and so that you can be more definite about your diagnosis. It is a soluble, water-soluble yellow dye, and the dye usually sticks to abraded areas of the cornea. The blue light here, using the ophthalmoscope light, the blue light of the ophthalmoscope, better shows the fluorescence of the dye. Ocular anesthetic drugs. What we usually use is your proparacaine. We use this when examining a patient with corneal foreign body who has difficulty to open his eyes. No? We also use this for corneal abrasion examination. However, we don't use anesthetics for long-term use. Why? Because it will delay the healing of the corneal surface. So please do not give this to your patients. When in the community and you have no other choice, you can use your regular lidocaine. We prefer the preservative-free one, the ones in your plastic canister. However, if you don't have this, the ones in the amber bottle will do. You can also use the topical anesthetics when you're planning to remove foreign body and among other things. Ocular dilating drops. This is what we usually use. It's called a combination of tropicamide and phenylephrine. We call it, it's called Sanmid. However, this is expensive. Sometimes you can use a pure epinephrine ampule. Okay, they'll just dilute it with water or saline, and you can drop it in the eye. Make sure that you occlude the punctum, no, so that the epinephrine will not go to the nasal mucosa and get absorbed and cause hypertension. You can use this when you're in the community and you failed to bring your Sanmid. When you want to examine, when it is critical that you will be able to examine the posterior pole, you are allowed to dilate the patient so that you can see better if there is indeed a problem in the macula or the optic nerve. Glaucoma drugs or intraocular pressure lowering drugs. There are a lot of these in the market, and they basically have three modes of action. One is that they suppress aqueous humor inflow. Second is that they enhance trabecular meshwork outflow. And the third is that they also enhance uveoscleral outflow. Okay. Those that suppress aqueous production could be your beta-adrenergic drugs, your carbonic anhydrase inhibitors, okay, and an example of which is your timolol. However, before using timolol, you have to ask for a history of asthma, because this dropping timolol can cause asthma, status asthmaticus. For carbonic anhydrase, we use acetazolamide, but be wary of potassium excretion through the urine. So you have to replenish your potassium with your banana or your potassium chloride solution. Okay. To increase uveoscleral outflow, we usually use the prostaglandin analogs, such as your latanoprost and your travoprost. So the names are very telling, no? This is your prostaglandin. The ending of the name is also prost over here. Okay. The side effects are usually hyperemia or red eyes, and there could be increased pigmentation of the iris and the periocular area. This can also cause lengthening of the eyelashes. There are drugs that have dual action, such as your brimonidine tartrate. They decrease humor inflow and increases uveous scleral outflow at the same time. Anti-inflammatory agents, there are also a lot in the market. They could be from mild, okay, from mild to moderate to strong. Okay. There are also non-steroidal anti-inflammatory agents which are also mild, and they are usually used for simple post-operative procedures. Examples of which are your Nepafenac and your Ketorolac. Steroidal agents such as your prednisone, which is the strongest by far, dexamethasone, and fluocinolone. They are used for post-operative control of inflammation. Also, when the patient has uveitis, allergic conjunctivitis, and in some cases, when there is very, very severe dry eye, we usually start with steroids. The downside of using steroids is that it can cause IOP elevation upon prolonged use only. However, if you're going to use it for a week or two, then it shouldn't cause you too much trouble. Oral steroids are reserved for more severe inflammation, such as your panuveitis, choroiditis, and the likes. Topical antibiotics. The first thing, they're usually bactericidal or bacteriostatic. Um, we have to warn you about the use of topical antibiotics because there's already reports of resistance even for the fourth generation fluoroquinolones. So please use this wisely. For simple prophylactic cases, you may use the polymyxins, neomycin, tobramycin, chloramphenicol. Okay. You can also use the macrolides, tobramycin and erythromycin, which also has an ointment preparation aside from the drop preparation. By the way, if the patient is unable to put drops on a regular basis, then you might consider prescribing ointment because the ointment can stay longer in the eye compared to the eye drops. Lubricants. There are also a lot in the market, and they are usually under these composition. No? You can choose whatever you want. It's over the counter. We prefer using the preservative-free eye drops for dry eye because they result to less damage to the conjunctiva, which we are trying to heal also. How about anti-allergy? These cases you will see also in the emergency room. So you will notice that chief complaint is usually that it is very itchy, and there's already bogginess of the eyelid, and even severe edema of the conjunctiva. You may opt to prescribe tablets rather than drops because the drops can cost around 700 to 900 pesos. A single tablet will only cost you around 5 pesos. So if the tablet works, then you're done with your duty. For very severe intractable cases, you may want to prescribe steroid drops also. However, the standard is for patients with who experience regular allergic conjunctivitis, you may prescribe olopatadine 3 times a day. Mild topical steroids can also be used, such as your dexamethasone and fluocinolone, but as I told you, if there's prolonged use, this can result to glaucoma. Please do avoid vasoconstrictors in treating your allergic conjunctivitis. That is the last of my slide. I hope you learned something, and please do review the slides and your lectures from the previous years to aid you in understanding these diseases. Thank you.